Please.
If many times after you have breast cancer, you take what, tamoxifen or Arimidex, how long should one take that? More than 5 years?
There are some very clean answers about this for some of it. And Cliff, do you want to do this one?
Sure, I need a microphone. So the duration of post-operative, what's called adjuvant hormone therapy, is pretty well worked out from really the largest randomized trials that have been done in breast cancer. Tamoxifen, which was the original gold standard, 1 year was better than nothing, 2 years was a little better, 5 years was better still, and it's not clear that 10 years is better than 5. So for the average person, we ended up at 5 years. Doesn't mean that there aren't individuals for whom 20 years wouldn't be better, and many for whom no therapy or 1 or 2 years might be fine, but we can't get to that level of granularity. This is important, though, because when the aromatase inhibitors were first brought into the adjuvant setting, that was the benchmark. So arbitrarily, 5 years of the first aromatase inhibitors were compared to 5 years of tamoxifen. And there was a superiority in the studies mostly for those drugs, and that became standard. This doesn't mean that the right duration for aromatase inhibitors is necessarily 5 years. It just means that's what we tested. And then we got a little more information. There was one trial and then another one where women finished about 5 years of tamoxifen. It was really about 4.5 to 6 years. And then if they were really menopausal, they were randomized to a second 5 years of therapy, in this case with the aromatase inhibitor. And the key study in that regard was positive. And so then you have this kind of mixed message if you think about it, right? 10 years of therapy sounds better if it's 5 and 5, but 10 years of therapy is not better if it's only tamoxifen. You have to keep that separate. That very study has been re-randomized so that the patients who got to 10 years have now been randomized for 15. A second 5 years of the aromatase inhibitor, all following 5 years of tamoxifen. I dare say if that study is positive, it will be a kind of a sea change for us because we'll have evidence that pretty close to the rest of your life is reasonable. It's hard to believe after 15 years of therapy that you wouldn't continue, with the proviso that competing causes of mortality go up with age, of course. And then finally, there are a couple of studies that have looked at shorter intervals. For example, 5 years of therapy, 2 of tamoxifen, and then 3 of the aromatase inhibitor, and those studies are positive. So the way in which an individual patient should be treated, by and large, should be in accord with whichever of those 3 models for adjuvant hormone therapy her doctor is following. And it's a little unsatisfying at the moment.
Ken? Yeah, please.
Yeah, just to say, I don't want anybody, and I know Cliff doesn't want you to think that everybody with breast cancer, if that study is positive, should be on lifetime aromatase inhibitors or whatever else, tamoxifen, whatever else. I mean, there are people that, if they reach 10 years, their risk of recurrence is so low that even if there was an additional benefit, it might be so minuscule that the side effects would outweigh the benefits. So I think we're mainly talking about women who still have an appreciable risk of breast cancer that may extend beyond that time.
Yeah, I want to agree with that. I mean, there are people who on paper finish 5 years of tamoxifen and would look like they're eligible for an aromatase inhibitor, but to pick an example, 9 millimeter ER positive node negative breast cancer, there's no evidence that they really benefit from the second 5 years of therapy, and the toxicities of the aromatase inhibitors, while medically milder, are often, from a subjective point of view, a little greater for patients. So I agree wholeheartedly that we will have to continue to individualize this decision, even if we have data for big groups of people.